Welcome, future RNs, to our review session. I'm here to guide you through this exciting journey as you prepare for the next generation NCLEX. And today we'll tackle key concepts, sharpen your critical thinking, and master those tricky standalone questions. We'll boost your confidence and get you ready to ace the exam. So here we go. Let's get started.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX Review Crash Course. The link is in the description. All right, now let's dive into the topic.
Our first case today is a Bowtie type of test item. And it says here, 42-year-old woman reports severe tiredness, a lack of energy, trouble getting up for her job in the morning, and difficulty focusing. She has gained 12 pounds in the past 15 days. The progress note says at 9:30 in the morning, the patient arrives at an outpatient clinic showing an enlarged thyroid gland, a puffy face, and dry, pale skin. Despite the warm weather, she is dressed in a thick sweater. She mentions widespread body pain, regular muscle cramps, and constipation. Her fingernails are fragile and her hair is rough and dry. She shares that she has been feeling down for the past few weeks. Vital signs include temperature of 96.4 degrees Fahrenheit, heart rate of 54 beats per minute, respirations 12 cycles per minute, blood pressure of 142/80, oxygen saturation of 94% in room air, and weight of 165 pounds. Also in our test results, we have hemoglobin of 9.2 grams per deciliter, hematocrit of 32%, thyroxine, or total T4, 3.5 micrograms per deciliter, and TSH of 24 milliunits per liter. Your task is to fill in the diagram by choosing from the options provided to identify the potential condition. The patient may be experiencing 2 suitable nursing interventions and 2 parameters to monitor to evaluate the success of the nursing interventions. So for the potential condition, the options are growth in the pituitary gland, hypothyroidism, hyperthyroidism, and gastrointestinal tract hemorrhage. So based on the progress notes and the laboratory tests, what do you think would best fit for the potential condition? Well, the answer here is hypothyroidism. So I want you to use the documented observations and the progress notes and the laboratory results in order for you to recognize the slowed physiologic processes. Then you're going to select that condition. And so I want you to go back into the progress notes and I want you to identify those things that would point to hypothyroidism. One of those is the severe tiredness. Or in the scenario itself, it said something about severe tiredness. There is difficulty waking. And also difficulty focusing. So this actually indicate neurologic slowing, which is consistent with hypothyroidism. and the presence of dry skin. Where is that? We have dry, pale skin, and also the hair changes. Take a look at the hair. There is rough and dry. The fingernails are fragile. So those actually pertain to the changes in the integumentary system due to the poor perfusion and reduced metabolic activity. The client also is complaining about the constipation. There is also presence of muscle cramps. It's sad that it's regular. And this points to the slowed gastrointestinal and muscular metabolism. And the fact that the client feels cold and also wearing sweater in a warm environment. So let's find that one. Yeah, dressed in a thick sweater. That demonstrates that the patient has cold intolerance, which is a hallmark of reduced thyroid function. And she also reported that kind of depressed, right? Feeling down. Shares that she has been feeling down for the past few weeks. And so this is something that you can link to low thyroid hormone levels as well. That's systemic depression. And focusing into the laboratory values right now, look into the TSH of 24 milliunits per liter and compare it to the reference range. This indicates that the pituitary gland is compensating for low thyroid hormone output. Now, look into the T4, total T4. And it says it's 3.5 micrograms per deciliter. This confirms that there is decreased circulating thyroid hormone that's supposed to be produced, right? And the client also has the bradycardia. That is very noticeable right here. That's low heart rate. And the temperature is slightly on the low side. It's not really that concerning, but it's going there. And the respiratory rate of 12 cycles per minute, that is borderline low, which are all consistent with a slow metabolic state. Now, don't stop there. We still have the low hemoglobin and the low hematocrit levels. The 9.2 and 32% hematocrit. This reflects mild anemia, which is commonly going to coexist with hypothyroidism. And so all these findings actually reflect the hypothyroidism. So all the combination of the elevated TSH, the low T4, and all the clinical signs of metabolic slowing strongly support that the client has primary hypothyroidism. It indicates that the thyroid gland itself is failing to produce sufficient hormone. And so this is prompting an increased production of the thyroid stimulating hormone from the pituitary gland. So why is growth in the pituitary gland incorrect at this time? Well, because when there is a pituitary tumor, this would also affect the TSH production, but it typically causes secondary hypothyroidism. There is going to be low TSH and low T4, or hyperthyroidism if the TSH is being secreted. Now, the high TSH and the low T4 suggest primary hypothyroidism, which reflects thyroid gland dysfunction. It's not a pituitary issue. And the symptoms like neurological deficits, such as vision changes, are actually typical of pituitary tumors, okay? Which is absent here. Now, why is hyperthyroidism incorrect this time? Why? Well, when you recall about hyperthyroidism, it involves excess thyroid hormone. It will lead to symptoms like weight loss. There's heat intolerance, there's tachycardia, anxiety, which are all opposite to the manifestations that we are seeing in this case. There's also heat intolerance in hyperthyroidism, which is exactly opposite to the observation in this client. And If you selected gastrointestinal tract hemorrhage, this is also incorrect. This is something that you would probably associate if there is melena, if there's black stools, but we don't have that evidence. The low hemoglobin and hematocrit are something that you can associate along the line, especially if there is systemic effect that could impair the production of the blood, especially if the erythropoiesis is being affected. But here, we don't have any signs of acute bleeding. No melena, no hematemesis are reported, so this is not the problem that you should focus on. Now let's move on to the 2 nursing interventions. We have options: instruct on methods to protect skin integrity, explain the significance of thyroid hormone replacement, share details about anti-thyroid treatment, promote higher calorie consumption, and provide education before thyroid surgery. Now, those 2 nursing interventions should include to instruct on methods to protect skin integrity, because with hypothyroidism, it causes dry, pale skin due to reduced metabolism and poor circulation. And when you are teaching skincare, such as moisturizing, avoiding harsh soaps, this will help manage the symptom and also prevent skin breakdown. So this aligns with supportive care for hypothyroidism. So my tip for you is that when you see changes of the integumentary system, you have to choose those interventions that involve prevention. So that could be moisturizing, avoiding skin trauma. Now, the next intervention that you should apply here is explain the significance of thyroid hormone replacement. Why is that? Well, first thing is you need to match the pathophysiology to the treatment education. Now go back into the clues that we have in our lab results. There is elevated TSH and low T4, which confirm that the client has primary hypothyroidism. The thyroid is not making enough hormone. And with hypothyroidism, this is something that you can treat, of course, as prescribed with thyroid hormone replacement. So that could be levothyroxine, and this is to correct the deficiency indicated by the low T4 and the high TSH. And take note that hormone replacement using levothyroxine is something to be done lifelong, and this is very important. And so the client needs to understand the purpose, the timing, and the importance of being compliant in taking this medication. This is a medication that they should be taking in their lifetime. And so when the problem is chronic and treatable, you have to expect teaching to be a correct nursing intervention here. Now, what about the other options? We have share details about anti-thyroid treatment. Why is this incorrect? Well, when we are talking about this refers to anti-thyroid medications like methimazole, which is supposed to treat hyperthyroidism. And this is going to reduce the thyroid hormone production, which is inappropriate here because our client in this case has low T4. This client needs more hormone replacement, not suppression. And the TSH is high, it is not low. And this is typically an opposite picture that you're seeing. And so you have to rule out interventions that can worsen the hormonal imbalance. Now, what else is something that you should eliminate? Here we have promote higher calorie consumption. Well, kind of sounds tempting to select this one, right? Because the client is reporting that she is fatigued, tired. But when you have a patient with hypothyroidism, they tend to gain more weight, which is a hallmark of hypothyroidism. And when you select this intervention, this is something that you can apply for hyperthyroidism, not hypo. Because if you're going to encourage more calories, this could worsen their weight gain. So I want you to match the intervention to the direction of metabolic change All right, so I hope that you're able to understand that. Now, lastly, we have provide education before thyroid surgery. Why is this incorrect? Well, this is pertaining to thyroidectomy, which is a treatment for hyperthyroidism, or possibly thyroid cancer or large goiters that could cause obstruction, some difficulty in swallowing. But this is not indicated for hypothyroidism. Even though the client has a swollen thyroid, surgery is not indicated based on the data that we are provided here. And so part of the elimination strategy here is to ask yourself, is this the standard first-line treatment for this condition? If it is not, then eliminate it. Now let's move on into the parameters to monitor. There are two correct parameters here. Of course, we have the options: vital signs, neurological status, blood test results, hydration balance, and blood loss. So the correct answers here include vital signs. You have to monitor for the improvement in the systemic function. So going back into the scenario, you already have the clues, right? Look back into the heart rate. This is very low, 54. Bradycardia. Temperature is slightly low. This is borderline low temperature, and the respiratory rate of 12 cycles per minute. This is borderline hypoventilation. And these signs reflect a slowed metabolic rate, which is a hallmark of hypothyroidism. And when you select vital signs, this is pertaining to monitoring those values, which will help you evaluate the effectiveness of the thyroid hormone replacement therapy, as they should gradually normalize once the client has established that therapeutic levels in their body. Now, my tip for you, especially when you encounter endocrine disorders like hypothyroidism, always monitor the vitals, because they show how the whole body is reacting to the hormone imbalance. Now, what else are we going to supplement here in the parameters to monitor? Well, the next one is blood test results. So your strategy here is to monitor therapeutic response to hormone replacement. Go back again to the laboratory results. We have a TSH that is 24, which is very high, and a T4 that is also low. And these two values confirm primary hypothyroidism. So you're going to monitor the TSH and the T4 regularly to assess if the dose of the thyroid hormone is adequate. So my tip for you, for chronic endocrine conditions like this one, the hormone levels are the key marker for treatment success. So always select lab monitoring when hormones are involved. Now, for the incorrect options here, we have neurological status. Why is this incorrect? Even though severe hypothyroidism in a case of myxedema, but we're not in that stage yet. The myxedema can cause neurological changes. It can cause confusion. But this client's symptoms are fatigue, depression, do not suggest advanced neurological impairment that requires specific monitoring beyond the general assessment. So this is not something that we need. And the neurological status monitoring doesn't really evaluate the interventions that we have provided to the patient. No, it doesn't. Now, what about hydration status? Do you think hydration status is going to evaluate the interventions that we provided to the client? No. This pertains to the fluid and intake and output monitoring, which is relevant when you are worried about renal issues, or let's say gastrointestinal bleeding, or fluid overload, or fluid volume deficit. But with the primary hypothyroidism, it doesn't really affect the hydration status unless it is complicated by, let's say, myxedema, coma, which is not indicated here. Now, blood loss, which is the last option here, is also incorrect because this pertains to monitoring, let's say, monitoring that will apply to gastrointestinal hemorrhage, which is supported by low hemoglobin and hematocrit. But the broader clinical picture here, we have a client that has thyroid swelling, abnormalities in the TSH and T4, which point to the hypothyroidism. So you have to eliminate the blood loss or bleeding this time. So I hope that you successfully selected all the correct answers in this Bowtie question. Let's proceed to the next case. And here we have a case of drag and drop cloze. This is pharmacology test item. And so let's get into the scenario here. It says a 56-year-old man was brought to the ED by ambulance after his son discovered him unconscious on the floor at home. Prescriptions include IV normal saline at 100 mL per hour, oxygen administration at 2 to 4 liters per minute via nasal cannula, a 12-lead ECG, complete blood count, a blood toxicology screen, and gastric lavage. Let's go into the nurse's practice notes. It says at 23:15, conducted an in-depth interview to gather the client's history with the patient's son. Patient has a history of headaches and depression. For the past 4 months, he has been using prescribed medications, including clonazepam, temazepam, and venlafaxine. His son mentioned that after losing his corporate job 8 months ago, the client has been isolating in his room, sleeping over 12 to 14 hours daily, consuming up to 4 cans of beer each day, and eating alone later at night after the household is asleep. At 23:30, performed a 12-lead ECG, collected blood samples for CBC and toxicology testing, started IV normal saline at 100 mL per hour as prescribed, with no evidence of infiltration at the site. Heart rate recorded at 114 beats per minute, showing sinus tachycardia. Noted T-wave inversion in leads AVR, V1, V2, and lead 3. At 23:40, set up for gastric lavage, positioned the client on his left side with his head tilted down 20 degrees, completed gastric lavage without complication. The client was drowsy but responsive to stimuli. Kept a close watch on vital signs. At 23:50, evaluated the CBC and toxicology results and reported them to the healthcare provider. Now I want you to go into the series of vital signs the nurse has collected. So we have temperature here. 23:15, it says 96.8 degrees Fahrenheit, O2 sat, 90% room air, 16 cycles per minute for respiration, tachycardia 116, blood pressure of 132/89, and later on at 23:30, the temperature is at 97.2 degrees Fahrenheit, saturation at 92% on 2 liters via nasal cannula. We have respirations of 18, heart rate 114, and blood pressure of 134/90. And about 15 minutes later, temperature is at 98.4 degrees Fahrenheit. We have saturation of 95% on 2 liters nasal cannula, and respiration is 20 cycles per minute, and heart rate 120 beats per minute, and blood pressure 128/88. Now, I want you to pay attention to the laboratory test results with the following values for the venlafaxine, 610 nanograms per ml, and I want you to refer to the reference range here. We got temazepam of 510 nanograms per ml, codeine of 400 nanograms per ml, clonazepam of 80 nanograms per ml, and acetaminophen of 7 micrograms per ml, and potassium of 3.8, red blood cells 5.6, hematocrit 43%, hemoglobin 14.2, lymphocytes 30, neutrophils 60, platelet count of 300,000, and white blood cell count of 6,500 cubic millimeter. So, your task is to select the most probable choices to complete the gaps in statements below using the options provided. So we have the statement here. It says, the lab results needing urgent attention include blood concentrations of blank, blank, and blank. And here we have the options of, for the blanks here, we have the venlafaxine, temazepam, codeine, clonazepam, and acetaminophen. I want you to scan through the results here before you decide which of these options should be to supplement the blanks in this question. All right, so I hope that you made up your mind. So the first answer that we have, in no particular order, really. So one of the medications that you should pay attention would be the concentration, the serum concentration of the venlafaxine. All right, so take a look into the level here. That is 610 nanograms per ml. That is way above the reference range. That is very significant. And also, remember that the venlafaxine is a serotonin norepinephrine reuptake inhibitor, or what we call as SNRI, antidepressant. And if there is an overdose, this can lead to serious adverse effect. The client could go into serotonin syndrome. They're going to end up with seizures, heart problems, which makes sense given the client's unconscious state and the history of depression. And so this situation needs urgent attention to assess for toxicity, and you have to take action here, like stopping the medication and also providing supportive care. Now, what would be the other medication that you should be worried about? The next one is codeine. So the codeine here is at 400 nanograms per ml. Supposedly, it should only be at 10 to 100 nanograms per ml. So this is much higher than normal. And we know that codeine, it is an opioid drug. This can cause serious side effects like respiratory depression. It can cause sedation or even coma in an overdose. This explains the client's unconscious state and low oxygen levels at 90% on room air. So here, it's important for you to act quickly to manage the potential for opioid toxicity, which could involve giving naloxone to reverse the effects. Now, last is to select the other medication here. So we have the clonazepam. What's the level in clonazepam? So it's 80 nanograms per ml. Supposedly, the therapeutic or reference range should be around 20 to 70 nanograms per ml. So this is a bit higher than the therapeutic range. And since clonazepam is a benzodiazepine, having too much of this drug can lead to sedation, can lead to respiratory depression, even unconsciousness, especially if this is combined with other depressants like temazepam and maybe alcohol. Although it's not as serious compared to the other two medications, but this is still something that still needs attention given the risk of overdose in this situation. Now, let's get into the other medication levels. So, what are the incorrect options here? So, temazepam, let's go into the level here. It's 510 nanograms per ml, so it's below the reference range of 600 nanograms per ml. So, even if the client is taking this benzodiazepine, the current level does not suggest toxicity or overdose. So it's not likely the main reason for the unconsciousness. So it doesn't need immediate attention compared to the higher levels of the other three medications. Now we also have acetaminophen is also incorrect. Go back into the level. It's 7 micrograms per ml. So it is within the normal range, and there's no sign of an overdose or toxicity like liver damage, and it doesn't seem to be causing the client's symptoms. So it doesn't require immediate attention in this case. So for you to answer the question correctly, you have to focus on those details that fall outside the normal range, because they are more likely to require immediate attention. And in this test item, the venlafaxine compared to the other drugs, we have codeine, we have clonazepam, are all elevated. If you are comparing it with the other two, like acetaminophen and the temazepam. So this is going to help you approach quickly to identify the values that could be critical. And after that, you're going to correlate the data with the clinical presentation. You're going to connect the lab results to the client's symptoms like unconsciousness, low oxygen saturation, and sinus tachycardia, right? There's that 114. And there is also low oxygen saturation, right? Where is that? 90% on room air. We have it right here at 2315. And the higher levels of the venlafaxine, the codeine, and clonazepam really match the symptoms of an overdose, like the central nervous system depression and the respiratory issues. Whereas the levels of temazepam and acetaminophen do not really seem to explain the client's current condition. So we gotta pay attention to those subtle findings and the lab results. Let's move on into our next item here. This is a matrix multiple response. And so let's get into the scenario. It says, a 29-year-old construction worker is transported to the emergency department following a fall from a 15-foot scaffold, landing on a pile of metal debris. He sustained multiple injuries, including suspected internal bleeding and fractures. Initial lab results show hemoglobin of 8.5 grams per deciliter, white blood count or cell count of 14,000, platelet count of 45,000, potassium 6.2, INR of 1.8, activated partial thromboplastin time of 50 seconds, and fibrinogen level of 140 milligrams per deciliter. We got a lactate of 5.2 milliosmoles per liter and the D-dimer of 2,500 nanograms per ml. So your task is to click the appropriate column to indicate the nursing actions that should be implemented on each laboratory result. So going back here, we have potassium 6.2, platelet count of 45,000, white blood cell count of 14, hemoglobin 8.5 grams, INR 1.8, and so forth. Now, what do you think would be done for this potassium level of 6.2? What do you think would be appropriate for this lab value? So, the nursing actions that you should be doing here is to start heart rhythm monitoring. This is too high. Remember about the reference range, it should be about 3.5 to 5 milliequivalents per liter or milliosmoles per liter. And this can really mess up with the heart rhythm. And it can also be an indication that there is massive destruction of muscles and tissues because of the injury. That is why there is massive release of potassium into the bloodstream. And this is very dangerous. It could cause those life-threatening arrhythmias. There's going to be peaked T waves, or it could even stop the heart from beating. And that is why we're going to put this client on the continuous cardiac monitoring device to watch the heart closely to catch any life-threatening arrhythmias. So if we are going to capture those arrhythmias, we can give the correct treatment, possibly calcium gluconate to protect the heart, or maybe to administer insulin plus dextrose to push the excess potassium into the cells. And so this action here is really spot on because it focuses on the biggest risk, which is the heart acting up from too much potassium. Alrighty. Now, why is fresh frozen plasma transfusion is not indicated here? Well, when you do this action, this simply means that you're giving this, we call that as FFP, right? Which is plasma. And it has clotting stuff like fibrinogen to stop the bleeding. But potassium is not about clotting, so it's about the heart rhythm. And the FFP does not lower the potassium level, or it does not fix heart rhythm. So this is something that you should not be applying here. So this is incorrect. Now, what about watching for signs of inflammation? Well, obviously, right, this is intended if the client may develop fever or redness, which makes sense for infection or swelling. But if you are focusing on the hyperkalemia, this type of nursing action will not address that. This is not going to fix the problem. Now, preparing for blood typing and matching. Do you think that this is going to help the hyperkalemia? Obviously not, because this is much more focused about another issue. Could be the bleeding, right? Or a low hemoglobin. But here, it's not applicable. Now, what about monitoring for signs of shock? Also not applicable, because this means that you are watching for a fast pulse or, let's say, low blood pressure. Of course, shock might make the potassium worse by causing some more tissues to be destroyed. But with 6.2, this is more about the heart rhythm. So this is something that that is more associated with cardiac monitoring. Now, preparing for platelet transfusion will not address that as well, because this is intended to restore the low platelet count. So again, your focus is about cardiac monitoring. Now, going into the next observation, platelet count of 45,000. What do you think would be the answer here? Well, the first one that we have is to land for fresh or frozen blood products to transfuse. Now, pay attention about the 45,000 of platelet count. This is very low. Normally, it's around 150,000. In some books, it's 250,000 to about 400,000. And that means the client might bleed more because the platelets is kind of depleted. And in this incident, when the client had a fall, there's probably internal bleeding, there's fractures going on, and this client will need all the clotting help that he can get. And the FFP will give him the clotting factors like fibrinogen that will be given together with the next action, which is to prepare for platelet transfusion. And this is to prevent massive bleeding. Now, in trauma, healthcare providers often give FFP with platelets and red blood cells together to stop bleeding fast. Now, why are the other options incorrect? Of course, watching for signs of inflammation is not applicable here because low platelets don't cause inflammation. They make you bleed easier. And this action doesn't fix or check anything related to platelets, so it's not right. Now, cardiac monitoring is not applicable here as well. This is intended for the hyperkalemia. And preparing for blood typing and matching. Now, this is not really indicated here, especially with the platelet transfusion. This is partially true for platelet, right? Because there is supposed to be ABO compatibility before you transfuse platelet. But the action also said something about matching. Cross-matching is not needed in this case because standard red blood cell cross-matching does not apply to the platelets, though specialized HLA or HBA matching may be used in refractory cases, but here it is not applicable. Now, what else do we have here? We have white blood cell count for 14,000 per microliter. What do you think about this one? What you're going to need to do here is to observe the signs of inflammation, especially that there is already leukocytosis. And after a big fall, it's probably the client is having all the stresses into the bodily tissues. It could mean early infection, like if dirt got into his wounds or the broken bones. So if you're watching for the inflammation, it simply means that you're keeping an eye out for fever, redness, or more pain, which tells us if he's getting sick or sicker, or if the injury is getting worse. And so this action fits perfectly because it matches what white blood cell count usually means in a fresh trauma like this one. So we need to catch this early. So the other options are incorrect. FFP is not going to address that. Cardiac monitoring is not really going to treat the elevated white blood cell count. The same thing with blood typing and matching, monitoring for signs of shock this time. Even though the level of the white blood cell count is elevated, you're gonna have to worry about shock if there is going to be elevated lactate, and we don't have that piece of information. What we have is currently stress and inflammation that's causing the elevation of the white blood cells, right? So watching for the shock is not really relevant here. The same thing with a preparation for platelet transfusion. Now let's move on to hemoglobin of 8.5 grams per deciliter. What do you think about this? Well, it will be matched with preparing for blood typing and matching. Look into the level. It's 8.5. It's way too low. And this is an adult person. Supposedly they should be around 14 to 18. So this means that this person has lost a lot of blood, probably visceral blood loss from the fall. And getting the red blood cells ready will fix this by replacing what this client had lost. And so this is going to help reperfuse those body organs in order to restore vital functions. Now, what else do we need to do here? We are going to monitor the client for any signs of shock. Because with this, when the client has low hemoglobin, he is at risk of causing low perfusion into the vital organs. And we are going to watch the client for their fast heart rate, their blood pressure, their oxygen saturation, their level of mentation, if they're going to be oriented or disoriented. So this will help us determine if the client is not supplying oxygenated blood to the body organs. And so this fits because the low hemoglobin from bleeding is a top cause of shock and trauma like this. And what else do we have here? We have INR of 1.8. So what do you think about this one? The INR of 1.8 should trigger you to plan on administering fresh or frozen blood product transfusion. So INR of 1.8 is already high. So it shows that the blood is not clotting well. So this is what we call now as coagulopathy. And in this fall, it's probably from losing blood or his body using up clotting stuff. And when you administer FFP, it has factors like factor 2, factor 5, factor 7 to fix this. So this is going to make the blood clot better. It's to stop bleeding. And so this is key with internal bleeding and fractures where the client needs to clot fast. And so FFP is the right move for this INR level. And so the rest of the other options don't apply to that. Now let's go into the APTT of 50 seconds. Remember about APTT? This is the coagulation test that we normally use when we are treating a patient with heparin infusion, right? And so APTT 50 is too high. It simply means that his body or his blood takes longer to clot, which is another coagulopathy sign. And this is caused by the trauma itself. He's losing or probably using so much clotting factors like clotting factor 8 or maybe 9 or 10. And so the FFP will actually help control this. And so this is going to make this patient into restoring those clotting factors as well to stop the bleeding. All right. Now, again, remember about the FFP. This is a go-to fix in trauma for a scenario like this one. So this is the perfect choice, especially for this abnormal lab value. And so the rest of the other options do not apply here. Now let's look into fibrinogen of 140 milligrams per deciliter. What do you think about this one? Well, what you're going to supposed to do here is to plan for fresh or frozen blood products transfusion. And so normally the fibrinogen is at 200 to 400. The client's value is 140. So this is the stuff that makes Klutz solid. And with bleeding from this fall, he's actually running out of that fibrinogen. And so in trauma, the low fibrinogen like this gets the FFP to keep the Klutz stronger. And so this action is just right for this level. And so the rest of the actions do not really apply. So let's proceed to the lactate of 5.2 milliosmoles per liter. Lactate. What do you think about the lactate? I want you to think critically here. The value is 5.2. Normally, it should be less than 2 or less or equal to 2 milliosmoles per liter, I should say. And so this client's value is so high, it means his body is not getting enough oxygen from the blood loss, like hemoglobin, that is already being low. And so what you need to do here is to monitor the client for signs of shock. And remember about lactate that is being released into the bloodstream when the body or the bodily tissues is not getting oxygen to help them do the metabolism, right? And so when there is a lack of oxygen to the tissues, they're gonna do their processes on their own with the absence of O2. So this is what we call anaerobic metabolism. So there is lactic acidosis. And this is a sign of shock. And in this trauma, it's probably from the bleeding inside. So you've got to watch for the tachycardia, low blood pressure, confusion, to check how bad the shock is and if blood or fluids are supposed to be given, right? So this action really fits because it really reflects that there is shock that is already going on. So you have to keep an eye on this one. Now, what else do we have? We have D-dimer of 2,500 nanograms per ml. And I want you to recall as much as you can what this lab value is for. And so what you need to do here is to plan for fresh frozen blood products, transfusion. It means that the clots are breaking down fast, maybe from trauma messing up clotting or early DIC with bleeding and fractures. And when you administer the FFP, this gives back factors like fibrinogen. And this will help stop the cycle and control the bleeding as well. Now, in trauma, the high D-dimer level gets FFP to fix the clotting mess, so this action is solid for the 2,500 nanograms per ml. And so the rest of the options here, such as watching for inflammation, is not appropriate. Starting cardiac monitoring is not going to address that. Same thing with preparation for blood typing and matching, and monitoring for signs of shock and preparation for platelet transfusion. So I hope that you're able to capture all those important and critical nursing actions appropriate for each lab value. Let's move on to our next item. We have a case. This is a highlight type of test item. So let's get into this scenario. It says the nurse assesses the nurse's note and lab results for a patient with heart failure who has come to the emergency department. So your task is to highlight the patient's information in the nurse's progress notes and lab profile that the nurse should indicate as significant. Now let's go into the progress notes here. At 9:45 morning, it says a 76-year-old female patient admitted to ED from the nursing home. Anxious demeanor observed. Complaints of chest palpitations and persistent dry cough. Breathing difficulty reported. Noticed blurred vision starting yesterday AM. Shoes feeling unusually tight per patient. Past diagnosis heart failure. 4 years stable until now. Current meds losartan 50 milligrams tablet daily, potassium tablet 10 milliequivalents tab daily, furosemide 20 milligrams tablet twice a day, digoxin of 0.125 milligram tab daily, height 72 inches, weight 180 pounds, lower legs show 2+ edema, skin Warm, dry, and intact. Vital signs of blood pressure 134/92. Temperature 96.8 degrees Fahrenheit. Saturation of 93% of room air. Respiratory rate 24. Heart rate 54. Lungs, bilateral coarse crackles are auscultated. Now, pay attention to the laboratory test results. We have serum digoxin level of 2.3 nanograms per ml, serum magnesium of 0.6, serum sodium 137, serum calcium 14 milligrams per deciliter, and serum potassium of 3.1 milliequivalents per liter. So what do you think about the scenario here? So I want you to think, what is the potential problem or the actual problem that is going on for this client based on the medications that are listed and also the history of this patient. So I want you to highlight the following if you were able to catch up. The first phrase that you should highlight here is the anxious demeanor observed. So in the context of worsening heart failure, since the client has had a diagnosis of heart failure for years, stable until now, this is actually one of those results or answers. So this is basically a sign that your patient has possibly hypoxia, of course 93%, right? And they have respiratory distress, 24 cycles per minute, and also bilateral crackles. So the anxiety is basically one of the early signs that your patient is not getting enough oxygen. And it aligns with the exacerbation of the heart failure and the associated respiratory compromise. Now, what else do we need to highlight here? We have complaints of chest palpitations. So this indicates arrhythmia, which can be caused by digoxin toxicity, which is above the therapeutic range. And this is a critical finding because arrhythmias are serious complications in this context, particularly with a focus on the cardiac glycosides. Now, what else you need to highlight? We have persistent dry cough, because this could be a sign of maybe side effect of a medication, though it is less common with the angiotensin receptor blocker compared to the ACE inhibitors. But this finding is also significant because it points to worsening heart failure and also a potential medication side effect. Now, what else do we have? There is that breathing difficulty reported. So this is also a hallmark of worsening heart failure, and this is caused by a pulmonary edema. Of course, there is that bilateral crackle. So for now, we're only able to capture that. There's no expectoration of productive cough at this moment yet. So it is probably evolving. And so this is actually being supported by those manifestations. There's crackles, right? And this is a critical finding because it indicates respiratory distress, also fluid overload, which are central to the patient's current exacerbation. And this also correlates with the patient's anxiety and decreased oxygenation. Now, what else do we have here? We have noticed blurred vision starting yesterday AM. So this is a classic symptom of digoxin toxicity. And of course, we have that confirmed in the laboratory result. This is highly significant because of our patient's use of the drug, and also the lab value supports that as well. Now, what else do we have here? The client feels that shoes feels unusually tight. So this indicates peripheral edema, which is a sign of fluid retention in heart failure. So this is actually confirmed by the swelling in the lower extremities. There is worsening of the heart failure due to maybe ineffective medication management. Maybe the client was not compliant. We don't know that. Or maybe the medication dose is not enough for this patient. And so again, this is a significant finding for this patient. Now let's move on to the next phrases that you need to highlight. Of course, we have past diagnosis of heart failure, 4 years, stable until now. So this is a historical finding that the patient has that diagnosis previously. It was well controlled previously, but now it is active. It is in the exacerbation period. The client is now having dyspnea, crackles, edema, and anxiety. And so this is a significant change in the client status. So it suggests an acute decompensation, possibly related to the digoxin toxicity, or maybe ineffective medication management. So let's move on to the next batch of phrases here. You should highlight losartan 50 milligrams tablet daily. Let me finish that. So this is also part of the highlight here, because this is a drug that is used to manage heart failure by reducing afterload and the blood pressure. And going back into the patient's blood pressure, it's 134/92. This is mildly elevated. And also the client has signs of worsening heart failure. It suggests that losartan may not be fully effective at this dose, or there are other factors contributing to the exacerbation. And in addition to that, losartan can rarely cause a dry cough, which the patient has, so this is a potential side effect. And this finding is significant because it raises questions about the medication's effectiveness and possible adverse effects. Now, moving on to the next medication is the potassium tablet, 10 milliequivalents tab daily. So this is a drug that is intended to prevent hypokalemia, especially in patients taking diuretics like furosemide. But the patient's serum potassium is low, 3.1. It indicates hypokalemia despite the supplementation. And so this simply means that maybe the medication is not enough for this client, right? And so maybe this will require medication dose adjustment. Now, what else do we need to highlight here? Furosemide 20 milligrams tablet twice a day. This is a loop diuretic that is primarily used to manage fluid overload in the heart failure. But despite the usage, the patient has significant edema. There is tight sensation with their legs. Shoes are not fitting well. There is lower leg swelling. There is pulmonary congestion. There is dyspnea, anxiety, crackles, all suggesting that furosemide at this dose may not be effectively controlling the fluid overload. And so this is also a significant finding that indicates a potential need for dose adjustment or maybe additional interventions to address the patient's worsening heart failure. Now, what else do we need to highlight here? We got digoxin 0.125 milligram tablet daily. And this is a cardiac glycoside. This is used in heart failure to improve the cardiac output and control the heart rate. But the patient's serum digoxin level is already high, 2.3. It indicates toxicity, which is supported by the symptoms like blurred vision. There is bradycardia. And so this is a highly significant finding, especially given the question's focus on the toxicity. All right? And of course, this is exacerbated by the low potassium as well and the other electrolytes. Now, what else do we got here? We have lower legs show 2+ edema. This confirms peripheral edema and also a hallmark of fluid overload in the heart failure. It aligns with the patient's report of tight shoes and indicates disease exacerbation. And this is possibly due to ineffective diuretic therapy as well with furosemide. And again, this is a significant finding that you should include. Now, what else we have here? There's that blood pressure of 134/92. It's mildly elevated. And in heart failure, our target reading should be less than 130. Okay? And in the context of heart failure, elevated blood pressure can exacerbate the condition because it increases the afterload. So it's going to make it harder for the heart to pump effectively. And another critical finding, because it suggests that the patient's blood pressure management may not be effective. That's worsening their heart failure. Now, what else do we have? There is that saturation of 93% on room air. This is below normal. The lower cutoff is 95%. This indicates hypoxia. Another significant finding, because this suggests impaired gas exchange likely due to a pulmonary edema that is evolving, which is supported by the crackles and the dyspnea. And this also correlates with the patient's anxiety and shortness of breath, reinforcing the severity of the respiratory compromise. And what else do we have here? There's that respirations of 24 breaths per minute. This is tachypnea. And this is a sign of respiratory distress, often due to pulmonary edema and heart failure. Another critical finding. Now, what else do we have? We have a heart failure of 54 beats per minute. This is bradycardia, because digoxin in itself can cause bradycardia, especially that toxicity is going on. Another critical finding. Now, what else do we have in the nurse's practice notes? We have the bilateral coarse crackles are auscultated. This indicates that the client has pulmonary edema, which is a sign of fluid backup into the lungs due to worsening heart failure. Another critical finding, because this confirms the presence of fluid overload, which contributes to the patient's hypoxia, and it correlates with the symptoms like dyspnea and anxiety. Now, moving into the laboratory test, well, obviously, I've already mentioned this earlier. This includes the serum digoxin level of 2.3. This reflects digoxin toxicity, a critical finding, and this highlights the need for immediate intervention, such as holding digoxin and also addressing contributing factors, maybe addressing those electrolyte imbalances that I'll be discussing further. Now, what else we got? We have the serum magnesium of 0.6. Remember about magnesium that is low? Yes, that is one of the contributing factors to digoxin toxicity. This will cause exacerbation, or it will contribute, it will worsen the effects of digoxin, right? And another significant finding that you should resolve this time. Serum sodium 137 is not really an issue. That is within the normal range. And what else do we have? We have the serum calcium of 14 milligrams per DL. Take a look at that. That is beyond the upper limit. Serum calcium is one of the risks. It will contribute to digoxin toxicity because it will enhance the effects of digoxin into the heart. This will lead to more arrhythmias, which is another critical finding here. Now, we have serum potassium, which is 3.1. Why do you think this is supposed to be highlighted? Well, hypokalemia will also enhance the digoxin's binding capacity to the ATPase pump. Remember about this one? And so this hypokalemia can worsen the digitalis toxicity and also contributes to the patient's risk profile. And that is why we need to address the hypokalemia this time as well. So I hope that you were able to capture all those necessary findings here. Again, the aim of this test item is to mark the data or information that are significant. It did not ask for information that requires urgent action, but we are tasked to collect those necessary informations that are significant to the CHF exacerbation for this client. And I hope that you were able to capture all those findings. Let's move on to our next item. We have our fifth item. This is a matrix multiple choice. And it says, a nurse is attending to a 46-year-old man in the cardiac progressive care unit after he activates his call light. Upon arrival, the patient reports feeling dizzy and queasy. He was admitted for monitoring following 2 episodes of passing out at home. The telemetry monitor displays atrial fibrillation with a heart rate of 146 beats per minute. So your task is to select the nursing actions below that are indicated or contraindicated for the patient's care. So let's go through each nursing action. All right, I hope that you're still with me. So the first nursing action says, check vital signs immediately. What do you think would be the best answer here? Well, this is going to be indicated because the patient is experiencing lightheadedness. They already have nausea. They have tachycardia. Imagine if you have 146 beats per minute and you are lightheaded, this is already a problem of tissue perfusion. Perfusion to the brain is affected here. And you have to quickly check the client's vital signs here to assess the circulation status. So check the blood pressure, pulse, their respirations, and O2 saturation to spot any worsening signs. You can decide later on what actions to take next. Now let's move on to the next nursing action that says administer oxygen at 2 liters via nasal cannula. This is also indicated because the symptoms could be caused by low O2 levels due to the rapid heartbeat. So this reduces how well the heart pumps the blood. And giving a small amount of oxygen, such as 2 liters per minute through the nasal cannula, can help tremendously for this patient to replenish oxygen to the tissues, especially if oxygen levels are already low or suspected to be low. So it is also a safe first step while further evaluating the client. Now, what else do we have? We have perform a 12-lead ECG. This is also indicated. Even though the heart monitor is already telling us that the client has a heart rate of 146 beats per minute, what you need to do is do that 12-lead ECG, which will give you a more complete picture of the heart's electrical signals. This is going to confirm the type of arrhythmia, show signs of the heart damage, or maybe other issues, and this will also guide the next steps in the treatment. Now, the next nursing action says encourage the patient to walk around the room. All right, what do you think about that? This is contraindicated because the patient feels lightheaded already and had 2 episodes of passing out at home. The blood is not really supplying enough oxygen into the brain tissues. That's why they feel that lightheadedness, dizziness, wheeziness. They feel nauseous. And it also raises the risk of fainting if you're going to allow them to walk around the room. And walking around the room this time is not really that advisable. For what reason? You're actually putting the client at risk here. So it is contraindicated. Now let's go into the next item. It says allow bed rest with permission to use the bathroom. What do you think about that? Well, this is also contraindicated. The statement or phrase that makes this one wrong is permission to use the bathroom. This one is correct. Even though resting in bed is very appropriate here, but if you let the patient to get up and use the bathroom, it's not safe right now when they are experiencing lightheadedness and a history of fainting and falling. And if they're unsupervised, this could lead to falls that will cause some more injuries. So the safer approach for you to do here is to put them on bed rest and teach the patient to ask for help when they need to use the commode maybe. So they're not supposed to walk far distances here. They need to be using alternative toileting devices. So it could be urinal or it could be a bedside commode. Now let's move on to our next item. It says, take no action, keep observing the patient. This is obviously contraindicated. You cannot let this thing, you cannot just leave the patient experiencing those signs of low perfusion. Okay, this is doing nothing. So you're actually putting the client at risk for more complications. Your client is already symptomatic. This could progress into maybe throwing a clot, so they could end up with a stroke. So never do this. And we have our next item. It says administer a high dose of caffeine to increase alertness. This is also contraindicated because our client's heart rate is already tachycardia. He is already tachycardic. And if you're going to give caffeine, this will speed some more of that heart rhythm. This is going to make their arrhythmia worse. And that's why we're not going to let this happen as well. Now, what else do we got here? We have notify the healthcare provider of the patient's symptoms. Obviously indicated, because our client here is having new symptoms along with the rapid atrial fibrillation. It's important for us to inform the healthcare provider right away. And once we do that, the provider needs to assess the situation themselves, and they may order treatments like medications, maybe blood thinners or anticoagulants, or maybe other procedures or diagnostics, which are outside in our scope of practice. And so you got to notify them if there are new changes, if there are sudden deviations in the nursing assessment. Now, what else do we have? Lastly, to record the occurrence of irregular heart rhythm. Well, this is also indicated. It is very necessary to document the episode of arrhythmia, including the heart rate, the symptoms, and what actions that were taken. And so this documentation will help ensure proper follow-up care. It will provide important details for the healthcare team and also support clinical decisions. Now, what I want you to have in this test item is to use the strategies to make sure you understand the patient's condition first. So before reviewing the answer choices, you gotta take time to carefully assess the case. You have to focus on the key clinical facts that you have seen in the scenario. There's that tachycardia, atrial fibrillations, the symptoms, lightheadedness, the nausea, past history of fainting, and realize that atrial fibrillation with a fast heart rate can lower how well the heart pumps, causing the symptoms. And a history of fainting suggests the patient is unstable. Once they get up from a supine position, they're really going to manifest those low perfusion symptoms, right? And another strategy here is to eliminate those obviously incorrect answers. So immediately rule out any choices that are clearly unsafe or will go against the standard nursing care for the situation. So you got to be careful with statements such as encourage the patient to walk around in this case, because it's unsafe when the client is feeling dizzy and they have already fainted before. And also discard indicated if you are giving 3 cups of brewed coffee, because again, caffeine make a fast heart rate worse, and this will increase the risk of arrhythmia. Even though that's obvious, I'm just throwing it out there. And if you mark take no action, keep observing as indicated, this is actually ignoring the client's current symptoms, and this could lead to serious complication. And also make sure that you are looking out for the keywords indicating urgency. Make sure that this is something that you should pay attention, especially checking the vital signs immediately. That is the key word right here, immediately. So this is calling for you to urgently evaluate the client status whenever they feel lightheaded. A rapid heart rate, even though it's already high there, if the client will probably be having another change, maybe if it goes up into the 150s, 160s, the more that their body tissues will not get any more oxygen. So then more falls can happen, causing more injuries for this client. So this is something that you should pay attention as well. And don't forget about practice time management. You're going to need to use this pattern to recognize, to quickly think and link symptoms with the correct actions. But don't overanalyze. You got to trust your clinical judgment and confirm with the logic. And so when you see signs of symptomatic arrhythmia, you should automatically think, check vital signs, give oxygen, get an ECG, and call the provider, because these are part of standard of care. And once you've marked those as correct, you got to check the other options to see if they might cause harm. So I hope that you were able to get all that.
Before moving ahead, here's something you need to hear if you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month, then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included. 100-hour animated mini crash course, perfect for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX ebook and 1-year access. Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX Review Crash Course. The link is in the description. Now, let's jump into the topic.
Let's have our next item. This is a extended drag and drop. So the scenario is saying a 58-year-old male arrives via ambulance after a motor vehicle accident. He is unresponsive with a Glasgow Coma Scale score of 6, shallow respirations at 8 breaths per minute, and an oxygen saturation of 82% on room air. The emergency department physician determines that emergent intubation is required due to respiratory failure and suspected airway compromise from trauma. So, your task is to identify which actions the RN can legally perform by dragging the nursing actions to either within the scope of practice or outside the scope of practice. We have the list of nursing actions at the bottom. The first nursing action we have is insert the endotracheal tube 5 to 6 centimeters past the vocal cords. Right. So what do you think about this one? Yes, it belongs to outside the scope of nursing practice, because this is a medical procedure that involves inserting a tube into the trachea to secure the airway. This is an invasive task that requires advanced training and licensure. Nurses or registered nurses are not trained this way. We are not licensed to do this task. And this is typically performed by physicians, anesthesiologists, or the CRNAs, paramedics, but not nurses. So let's proceed to the next nursing action. It says arrange for a rigid tonsil tip suction device to be readily available. This is within the scope of the nursing practice because we are responsible for preparing equipment for emergency procedures. So you got to make sure that a rigid suction tip, or this is what we refer to as young power suction tip, at the bedside to ensure immediate availability to clear oral secretions during the intubation process. So this is also essential to maintain a patent airway and also part of our standard nursing responsibility. Let's move on to our third nursing action. It says deliver 100% oxygen to pre-oxygenate the patient. Yes, this is within the scope of the RN practice because this reduces the risk of hypoxemia during the intubation. And this probably refers to administration of O2 via face mask or the bag valve mask as a nursing function performed under protocols or the provider orders, and this one supports safe airway management and is a critical nursing intervention as well. Moving on to the next one, align the patient's head and neck in a sniffing posture. What do you think about this one? This is within the nursing scope of practice. This is the correct position for intubation, wherein the head is extended, the neck And also, this is going to improve the visualization of the vocal cords and facilitates the successful intubation. So nurses, especially RNs, frequently assist with the procedure positioning. So this is clearly within our scope of practice. Number 5, we have determined the pre and post-procedure medications, obviously outside the scope of RN practice. The selection of medications, such as the selection of sedatives or the paralytics for intubation, requires prescriptive authority, and we don't have that. So this is only going to be acted upon by the medical provider. So nurses can administer medications when ordered by the care provider, but we don't get to choose or determine the drug regimen for the medical procedures. Let's move on to the next one. We have obtain vital signs before the procedure. What do you think about this? This is also within the scope of practice, assessing and also documenting those vital signs before a procedure is a core nursing duty. It will give us baseline for monitoring patient responses during and after intubation. So this is a routine and necessary task for RNs. Let's have our next one. Pick the correct size of laryngoscope. Well, this is outside the scope of practice. This is a decision made by the provider performing the intubation. Even though we're only assisting, you got to be ready though. If this is the age group of this patient, you kind of expect though, but we don't get to pick the correct size. All right. We only assist with the equipment preparation, but we do not make the procedural device selection like this. Now, we have verified that the bedside suction equipment is operational. Of course, this is within the scope of practice. This is part of our task, making sure that the emergency equipment is functional. And this is to provide safe environment, making sure that it's ready to go to avoid delays during the airway clearance, and this supports patient safety during intubation. What else do we have? We have decide on the appropriate endotracheal tube size. Obviously, outside the scope of RN practice, this requires clinical judgment and expertise in the procedure. And this is a decision that a physician or an advanced practitioner can do. We do not select airway devices, though we can prepare, but we don't do the selection. And promptly alert respiratory therapy to secure a ventilator. This is within the scope of RN practice. We do the coordination, so when you notify the respiratory therapist to prepare the ventilator, this is going to ensure prompt support for mechanical ventilation after the intubation. And also we have to maintain that communication with the other healthcare team members so that we can coordinate and appropriately deliver those necessary interventions. So for this type of test item, I want you to anchor yourself in the registered nurse's role. And when you answer this type of question, you got to ask yourself, is this something I, as an RN, would routinely do on the nursing unit? Or is this something that requires decision making? Or is this a procedure that is reserved only for a healthcare provider? Then if that's a yes, then if you said yes, that this is a procedure that a healthcare provider can only do, then put that as outside of the RN scope of practice. And so our role as RNs, we have to prepare equipment. We can assess the patient. We can report findings, administer treatments, medications as ordered. We can coordinate care with the healthcare team. And for those tasks that fall outside the scope of the RN practice, this includes prescribing medications, performing invasive procedures like intubation, and formulating a medical diagnosis is not part of our practice. And the same thing with choosing the size of the equipment. like an endotracheal tube, or let's say the laryngoscope. Those are outside of our scope. And so I hope that you're able to capture the essence of the options that we have for this test item. And so this wraps up our Q&A today. And you've got to keep practicing. You've got to trust your instincts. And remember, you've got this. So thanks for joining me today. You've got to study hard, stay focused, and I'll be rooting for you as you step into your RN future. Thanks for watching.